There's lots of multi-center data, but the problem for FDA-approved CAR T-cells, but the problem is that the CAR T-cell data is really limited to 2-year follow-up. We conducted a similar single institution study at the University of Pennsylvania using the same CAR construct as that used for Tisagenlecleucel or the Juliet study. And so using our single center data, we went and looked at our long-term outcomes. So we're specifically interested in, obviously, clinical outcomes as well as long-term events, such as toxicity. So we looked at both patients with diffuse large B-cell lymphoma and follicular lymphoma, and basically we specifically were interested in looking at what happened after patients were at least 12 months in remission. So for people who had a 12-month response, at least with diffuse large B-cell lymphoma, there's actually only 1 relapse, and we had a median follow-up of 49 months. That was single relapse happened at 35 months. And so that was very exciting to see that these responses appear very durable. This was similar for follicular lymphoma, where we saw 14 patients treated with CAR T-cells, 3 relapses after 12 months. The trial data that we had was appeared very similar, at least on first pass, to the Juliet data. We infused a total of 38 patients. And so obviously it's a smaller subset, but in terms of toxicity and in terms of early responses, they appear remarkably similar to Juliet, versus this is the first long-term data. We were also particularly interested in looking at hypogammaglobulinemia, which is a known side effect from the CAR T-cells because they target all B cells, both benign and malignant. And we saw that there was very little use of IVIG, despite the fact that many of these people develop hypogammaglobulinemia. On this trial, we treated with IVIG for severe recurrent infections, and only 3 of the 38 patients treated required IVIG initiation while in this trial. We also saw 2 incidents of myelodysplasia that happened at 8 months and 40 months, but that's about similar as we would expect for another population treated with chemotherapy. And then finally, we didn't see any evidence of replication-competent lentivirus, so this is of a concern because we use lentivirus as a way to transduce these T-cells to manufacture CAR T-cells, and we saw no evidence of that. So I think this data is really exciting, especially for diffuse large B-cell lymphoma, because traditionally we see that these relapses tend to happen very early with CAR T-cells, mostly within the first 6 months, but certainly within the first year. And we think of diffuse large B-cell lymphoma as having a much better prognosis if people are more than 2 years out from therapy, and now we're at 4. So I think the 4- and 5-year data is going to be extremely important. I think the big question is, can CAR T-cells be moved further up in terms of therapy? So these are all 3rd-line treatments or higher for diffuse large B-cell lymphoma, and they're currently randomized controlled clinical trials. We're comparing CARs in 2nd-line therapy and randomizing against autologous stem cell transplant. So I think that's the next data to really watch for. And this is being done in multiple different CAR products, both with isocaptagene-ciloleucel as well as Tisagenlecleucel, and isocaptagene-maraleucel also, or JCARS also has one as well. And then finally, the CAR combinations are also very exciting, specifically combining checkpoint blockade with CAR T-cells, as well as BTK inhibitors such as ibrutinib with CAR T-cells.